السلام عليكم جميعا. آسف ما قدرش نتمكن نحضر معاكم الميتنج، لكن يسرني أن نشارككم بالزوم. أنا دكتور سامي جليدي، أخصائي قرنية. هنتكلم اليوم على الانتركورنيال فور كيراتوكونس. بالنسبة للكيراتوكونس مانجمنت، أي مريض عنده كيراتوكونس يهمنا to improve the vision. So to improve the vision، أول شيء ممكن النظارة is a spectacle, but later on, you may consider rigid or scleral contact lens or hybrid intracorneal ring. For selective cases, you could using phakic implants such as ICL or Artisan. And also for selective cases, you can using topo-guided BTK. الحاجة الأخرى, to stop the disease progress for keratoconus, usually do cross-linking. Intracorneal ring can add a bit of strength, but not the main reason. The other thing when advanced keratoconus, you need to consider keratoplasty, Sadalk or dendritic keratoplasty. You could consider for selective case Bowman layer or corneal lay. For acute hydropus, to speed the recovery, you could consider air injection in AC or suture. The other things we shouldn't forget, treat the allergy and atopy, and very important to ask the patient to stop eye rubbing. And eye rubbing is one of the factors where it can cause the keratoconus to progress, even if you do cross-linking or rings. بالنسبة للانتركورنيال ring, it's a minimum invasive procedure, a reversible option to improve the shape of the cornea and avoid and delay the need for corneal transplant. There's no removal of tissue, so we don't make the cornea weaker, and also preserve the visual access. It's useful tool to visual rehabilitation for keratoconus grade 1 to 3, and there's different type of intracorneal rings available. The initial one they call BMMA, which is a plastic made material. They have different size, thickness, and diameter. Intax SK, the first one, and nowadays we use more Ferrera and Kira ring. My ring is one single rings. Nowadays, most people, they don't use that rings. There's a new design emerging now. There's like what you call progressive thickness, where the thicker in one side and thinner in other area, which can be used for selective cases. There's another modality now, what we do, we're using a corneal tissue, a corneal graft tissue, and use that corneal graft instead of the plastic BMMA rings. And educated by Susan Jacob 2018. It's very promising. The advantage of tissue, it's reduced the risk of melting, necrosis, extrusion, and migration. And there's a possibility, some people reported that you can adjust the tissue and customize after the implantation. But still, long-term result not clear, but also the nomogram is very tricky because not as the plastic where it's more fixed nomogram, so still we're looking for a better nomogram. This is one of the cases where the rings, intercorneal ring cares. So this is the graph show that the patient, this is before cares, and this is after cares, and this is how much improvement of the patient after the corneal tissue inlay. Regard, this is OCT cornea, which you can see the BMMA in the top one and the Kera rings in the bottom. Usually Kera ring is using wider segment. To choosing the rings, usually we choose it guided by cone location, refraction, coma, and corneal topography. If it's central cone, sometimes we're using two symmetric ring, but if it's the asymmetry, we may use single or asymmetrical rings. What intracorneal ring do? It's, as you know, is a modern minimum invasive procedure which improves the shape of the cornea. So by improving the shape of cornea, that reduces the high order pressure, which mainly in the keratoconus, the coma, affecting the vision more. It reduces the cylinder and the myopia, and can also improve people who had contact lens tolerance before become tolerant to contact lens because we reduce the bulge of the keratoconus. So by doing the ring, improve the quality of vision, improve the unaided corrected and best corrected visual acuity. Still the aim of the ring, not to no glasses, but the patient still need the weaker glasses, but he can see with the glasses. The other things with the rings that it can, because we added things to the cornea, so technically we strengthen the rings by doing the intracorneal ring, we strengthen the keratoconus. The technique, the ring inserted at the tunnel, usually at the 70 to 80 thickness of the cornea at the tunnel side, using manual femto laser, but nowadays really we're moving to use the femto laser for all our rings because it's safer, less discomfort, faster creation with little disturbing to the tissue. But more important, really, the tunnel diameter, depth, and centration is very precise. So we had the better way, better customization of the rings, and that will help us to get better result, but also safer result. You could do cornea cross-link with the ring, same time, but always most of us recommend it to the intercornea ring first, then waiting for a month or two, and then do the cross-linking after. The other things, if someone had very much irregular cornea, you could do the intercornea ring to improve the shape, and then you can fine tuning with the BTK with and cross-linking. Regarding the systemic review and study look into the intercornea ring, the reason for why we removing the links, look into 39 article published. Most of the surgeon they look at using Kera ring and Ferrar ring, less intact. The number of explantation is greater intact, like 90% compared with the 1% Kera ring. Most intact was implanted because the patient vision not as good. So that's the patient did the rings, the vision not as happy with the vision, you remove it. Kera ring and Ferrar ring in the study shows more effective in keratoconus than the intact. So nowadays, really, most of us using Kera ring or Ferrar ring, which is both equal. Complication more in the patient had ocular atopy, dry eye, lack of thalamus, blepharoconjunctivitis, people had herpes simplex keratitis or blepharitis. Atopic dermatitis associated with increased risk of intercorneal ring extrusion and need to be treated before consider the rings. Look at the other study, look into the incident and reason why we remove the rings. Published in the American Journal of Ophthalmology, look at 1,644 consecutive cases and over 10 years. So the explantation rate is 5.6%, so it's low. But why we remove these rings, what we call function failure, whereas 61% of the patient, we removed the ring because the vision wasn't as good as we wanted. The other 39% of the patient, we removed the rings because the problem with anatomical failure, like spontaneous extrusion, infection, keratitis, corneal melt, or very, very rare 1% corneal perforation. Mild cases of keratoconus were brought to explant it or remove the rings more because these people had a reasonable vision. When they put the ring, may not be as happy with the gaining, so they may ask you to remove the rings. The other things, the spontaneous extrusion, and the problem is more with advanced cornea. When the cornea is very steep and thin cornea, there's more risk of extrusion of the rings. Exposing factor. High exposing factor, high mean K, more than 55, had significant inferior and corrective visual outcome post-operative, and their vision may not improve to 20/20, so under 20/40 nil chart. However, they gain more because they already had poor vision before, so the patient gained more lines of vision. Patient were more advanced keratoconus topography, steep K, for example, a high K factor, K max, or prolate cornea with Q value high inferior symmetry, high aberration cornea, steep cornea, tends to gain more line, post-operative and corrective visual acuity. Infection is another cause where the segment can extrude it through the tunnel. Who is the good candidate for intercorneal ring implant? Usually above 18 years old, people who cannot tolerate contact lens, poor best corrective visual acuity, correct distant vision 20/40 or less. Cornea barometer should be more than 400, better 450 at the tunnel area, stage 2 and 3 keratoconus, and patient who doesn't have central corneal scarring. Patient who maybe not the best candidate for intercorneal ring, if someone had a corneal scar which affect the vision, so the ring will not help. Pursued mild degeneration, patient with severe keratoconus, K reading more than 55, patient had previous high drops, patient had previous corneal cross-link and the cornea is stiff. So when you put the ring, maybe less likely to modulate it with the rings, this if it's like a version I. Post-LASIK ectasia, especially if the corneal flap LASIK is thick, so the stroma underneath is thinner. Need for thick segment because very high steep K. Patient with pericardial erosion, patient with ocular surface disease such as blepharitis, vena keratotic conjunctivitis, severe apotopic disease, patient who rubbing their eyes, that's make the cornea progress, but I have patient who has rings itself broken in the cornea. I have to remove it because he rub his eye. A patient with autoimmune disease and immune deficiency. The success rate of the intracorneal implant is highly depends on surgical experience. Let's show the study people who surgeons who do more surgery, they have better result. Appropriate basis selection. We need to adhere to the nomogram, implantation nomogram in the corneal ring type because different rings can do better. As we say, Ferrari ring and K ring tends to do better than other. Method of tunnel creation really is very safe and effective. Better way to use the film to laser now than to use the mechanical device, but still overall complications is low. This is one patient which I did the intercorneal ring, two segment, one thicker and one thinner inferior. And this is the central one. This is before the surgery, and you can see the steepening. And this is after the intercorneal ring. And this is the compare the improvement in his corneal shape. And this patient vision unaided corrected 120, improved to 6.9 unaided. And the fraction, he was almost 6, the diopter astigmatism become 125. So it's a big improvement for this patient, and also the Q value. This is another patient. Basically, he had the keratoconus, steep carotid contact lens, and this patient I used one segment only, inferior, and you can see the picture here, and the vision improved from 636 to 6.5, and this corrected vision improvement from 612 to 6.6, and the stigmatism also improved from 4 diopter to 1 diopter stigmatism, same also the Q value. After a few months, I did his left eye, which also are using the femtosecond laser, tunnel 4.7 to 5.7, and using just one segment inferior because as we see his cornea before surgery is symmetry, and one segment is enough for him. And that's the same things, big improvement in all the parameter from the K value, the best corrected and corrected and refraction. This patient, once I did the cornea ring, then I waited a few months and I did cornea cross-linking after the surgery. And this is the for right and left eye. This is the one first before the intercorneal rings. This is after, and then after the cross-linking, this patient was stable for the last few years. So conclusion, in patient with keratoconus intercorneal ring as a good treatment option prior to consider cornea graft. In contact lens intolerance patient, or patient doesn't want to wear contact lens, the success of intercorneal ring is high, depends on appropriate basis selection, surgical experience, intercorneal ring types, and adherent to the suitable implanted nomogram. Better, as we say, to use the 50-second laser to creating in the tunnel. Visual result after intercorneal ring is highly unpredictable. However, it can be adjusted and easily reversible by removing the intercorneal ring. Treat any ocular surface disease before intercorneal ring insertion. Overall complication really is very low and really is a very rewarding procedure. And thank you very much. إن شاء الله نلتقي في مؤتمر physically إن شاء الله قريبا.